The broadcast is now starting. All attendees are in listen-only mode.
Welcome everyone to today's program. I am Lindsay Dunn, Editor-in-Chief of Becker's Hospital Review. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions they can during the time that we have, and that will be at the end of the presentation, and we'll follow up on any questions that they did not have the opportunity to address following the end of the presentation. After the presentation today closes, you will receive an email in about a week following today's webinar that will have instructions on how you can download a copy of the presentation. You'll also receive a follow-up email shortly after completion of today's program, and you can submit any feedback or additional questions that you have at that time. It's now my pleasure to introduce today's presenters. Linda Mccracken is Vice President, Advisory Services at Truven Health Analytics. Linda has over 20 years of experience in the healthcare industry. She leads the advisory services to drive evidence-based solutions to business issues with teams in consulting and solution development. Her work at Truven Health has resulted in launching outpatient solutions, business development, and consumer engagement. She currently holds an appointment in management at the Masters of Management program for physician and dental executives at the Harvard School of Public Health. She has co-authored several white papers with Truven Health Analytics colleagues. Our second presenter is Bob Kelly. He is Senior Vice President of the Center for Healthcare Analytics at Truven Health Analytics. In his role, Bob is responsible for the development and ongoing enhancement of all analytic methods incorporated in Truven Health Analytics decision support applications. These applications are used by health plans, large employers, government agencies, hospitals, and healthcare systems to evaluate and identify opportunities for performance improvement. Bob is responsible for Truven Health Analytics Medical Episode Grouper, one of the leading episode groupers. He is an expert in both the clinical and statistical methods applied to the grouper and is knowledgeable of the challenges and appropriate solutions in the use of episodes for evaluating cost efficiency and resource utilization. He was also the principal investigator on a CMS project to develop a prototype medical episode grouper for Medicare. It is now my pleasure to turn the floor over to our first presenter, Bob, to begin today's presentation.
Thanks, Lindsay. First slide. This is a little bit. I'm going to go over the agenda. We've got 4 topics that we're going to talk about today. I'm going to cover 2 of the topics, and Linda will cover the additional 2. We want to talk about strategies for providers, health plans, and employers to manage the newly insured. And we'll get a little picture about sort of the difference between what providers, health plans, and employers are looking forward to in terms of the new responsibilities and pressures and issues. We want to focus on the expected characteristics of the newly insured population and also the newly Medicaid eligible, and we'll talk a little bit about the differences between the 2. We're looking at how we might find opportunities to manage this population. We'll focus a lot on the need to consider the characteristics in a local marketplace and in your marketplace in particular, and talk about how to work with teams to better manage use rates. Next slide, please. So we start here with just a real simple, I guess this is the slide to tell us we're near the end of the beginning. We look at the ACA implementation. It started in 2010. I'm sure you're all aware of each of the steps in this process over the last several years. And what we're looking forward to right now is the changes that will sort of culminate in 2014 with Medicaid expansion, the individual mandate, in particular the health insurance exchanges. So what we want to focus on is what do we think we're going to see in 2014 and how might we best respond to that. Next slide, please. So this is meant to, I guess, surprise you a bit, and I will tell you that you don't have to understand what this is, and I'm not going to spend a whole lot of time going into this, although in a presentation that I made earlier this year, I actually did use this as a structure for presenting what might in fact be the impact of health reform in the marketplace. And the question I basically asked was it as simple as sort of solving a set of 3 simultaneous equations? And what you see here is my attempt at developing I am trained as an economist, at developing a set of equations that, if solved simultaneously, would tell us exactly where everything was going to end up. And so this idea of, is this a deterministic model? And in fact, what you're looking at is the first equation is what hospitals and providers may be focused on, which is minimizing the loss of income associated with healthcare reform. The second equation is an equation that relates to the health plans and the payers and their attempt to maximize their net income in the presence of uncertainty. And then finally, we're looking at what the employers might consider to be their objective, which is to minimize the increase in costs that they might experience as a result of reform and potential cost shifting. So obviously a little facetiousness here, but the idea is that there are different objectives for the different constituents in the marketplace. Each sort of is pursuing their own objective, and the result will be due to how sort of things even out and how these different objectives interact. Next slide, please. So, sort of, am I kidding here with a suggestion that this might work? So we work through the slide. My reason is following. Remember that this is a market, and there is some type of economic modeling that might actually be useful here. I know that what I'm showing here is certainly not adequate, but the point I'm trying to make is that this is an economic model. The results in the marketplace will depend on how the different constituents pursue their objectives and how they relate to each other. I'm probably making a point about the fact that even though there is a sort of market solution here, it is very complex, and the interdependencies and the eventual success of healthcare reform depend on how the individual stakeholders pursue these objectives. I think that exploring these decisions will provide some insight, even if we obviously can't solve a set of simultaneous equations in this complex marketplace. By looking at some of these objectives and how the constituents will optimize or pursue them is going to provide us with some useful information. And then finally, this might not work, but you certainly won't forget I tried, and you won't forget what these equations suggest. Next slide, please. So again, in a previous presentation that I made, I actually pursued each of these equations, but I thought here, for the purposes of looking at the newly insured, that we'd sort of dig in a little bit into the health plan equation. And so if we look at this, basically what this says, and what's most important here, is that as a health plan makes a decision about whether or not to participate in the health insurance exchange, they have to think about their participation. They have to think about what price they're going to charge. That has to be related to their expectations around membership, selection biases, what kind of utilization, what kind of clinical characteristics to expect in that population, and will it be the same as their existing mix, their commercial mix? Will it be different than their non-group populations? Will it be less expensive, more expensive? And if you look at factor 3, the actual cost per member, this is sort of the key to this equation, which is it's the expected cost minus an error term. So, what we've got at our health plans frantically calculating what might be the expected cost in each one of these coverage levels, and trying to minimize the error, because essentially if they set the premium rate based on what their expectation is, and they get a different kind of mix of patients in terms of risk, they are looking at a loss, potentially a significant financial loss. So what we want to do is talk now about what they might expect and how they go about considering that. Next slide, please. So if we think about their pricing strategy, they need to focus on what the expected risk profile of the exchange market. And if you're a provider organization and you are considering participating with one of these health plans as they approach the exchange market, this is going to be of significant interest to you. Or if you are asked to assume some level of risk associated with this population, these same considerations are going to be important to you. The question that the health plan and a participating healthcare organization needs to consider is, if this is the risk curve, where am I going to set my price? Am I going to sort of actively pursue a large health exchange market, a large market share of the health exchange? If I do so, I may in fact be sort of minimizing my risk because I can be spreading the risk over a much larger population. If I don't approach this market aggressively and I focus sort of on price, I may in fact attract a market share in a population characteristic which is unfavorable. You sort of look in this the last point here about the age-rated band. It puts them over the edge. This is a quote. But the question is, do I want to come in aggressively with low price, get a bigger piece of the pie, or do I want to be conservative and come in with a high price and effectively attract the wrong kind of risk? Next slide. And this is just an example of how, in fact, they might set these three different age bands and what the price might look like in each of those. And if they set them incorrectly and they attract a different kind of risk, what they end up with is a cost that exceeds their payment. And again, this is the same profile that might be presented to a participating hospital or healthcare organization. So let's look at some information that we know, or that at least we can anticipate about these newly insured and what the impact on the market might look like. So we've made estimates. We've made these estimates by very specific geographic regions and rolled them up to national, state, and national figures, and you'll see some of these in some following slides. But the bottom line is, we're projecting that there'll be about 14 million Americans that will get their insurance through the insurance exchanges and through Medicaid expansion in 2014. This number will increase to 34 million in the next 3 years. That increase will be due to some changing demographics as well as some shifts among the members in terms of incentives and familiarity with the exchanges. Next slide, please. So let's look at the pattern or the trend of these over time and what we're projecting is going to happen. You sort of see the exchange and the Medicaid expansion unrolling in 2014, where we've had a consistent sort of numbers over the past. These are in changes in the millions, so you see what's happening. Some are increasing and some are decreasing. The expected decrease is happening in the uninsured. That's the actual purpose and the objective of reform. And so we show that we're looking at a 30 million, eventually 30 million decrease in the number of uninsured, which is going to be matched on the top half of the trend graph by increases in the exchanges and in Medicaid. But what you can see, we show in our projections for the longer term is the biggest increase is going to happen in the exchanges. You see a slight decrease in individual coverage outside of the exchange and a slight decrease in employer-sponsored insurance over that time period. But basically, those remain relatively constant, with the big shift, as expected, coming from the uninsured into Medicaid and into the exchanges. But the question is this is a large change, but which ones are going to be sicker? And what are the characteristics going to look like? And that's what we're going to talk a little bit about. Next slide, please. So obviously, the biggest impact on sort of the shift of the uninsured into either Medicaid or into the exchanges is the decision by each of the states to expand Medicaid eligibility. The current, this is Washington Post in April, and I think it's it's relatively still pretty reflective of where the country is, where the states are. But the idea is that there are a large number of states that are not expanding and not expected to expand Medicaid, in which case the newly eligible will be showing up on the exchanges. In other states, we see the expansion of Medicaid, and we'll see less movement into the exchanges. Now, the other factor that's important here is to understand sort of what Medicaid enrollees look like in each of these states and even local areas, in the sense that you may be looking at a state that has a very low Medicaid enrollment currently as a percent of population relative to other states, and see a much bigger impact of the decision not to expand Medicaid. And Texas is an example where a large number of people will become eligible, and a decision to not expand Medicaid will basically send those people into the exchange. Next slide, please. And then the next factor, which is unclear yet as to what impact that this is going to have, but is certainly of concern to the states, individual states, and to the health plans that are considering making offerings on those state exchanges, is whether the exchange will be state-operated, federally operated, or a partnership, basically a hybrid of federal and state. And what this slide shows is that there is a mix, a pretty even mix across the country in terms of those three different characteristics. Now, as I say, it's not clear yet exactly what that impact is going to be, but you must understand that that there is a relative risk to both payers and providers that is presented by the potential successful operation of those exchanges and their ability to, for example, engage their members in making effective decisions about their health care coverage and about maintaining their health. These become, the exchanges in many cases become the vehicle for sort of managing how the population accesses health care and how they pursue their own health. Next page, please. So as these three constituents look at these newly insured, what challenges do they see and how are they approaching? And Lindsay, I'm sort of going to ask you to try to stay with me, and this is a building slide. The payers. So the payers certainly are seeing a higher risk of cost, and they're seeing that regardless of any effect of reform. As we've known, for years now, the medical costs have been increasing at a rate eclipsing the economy, and there's still this concern that these costs will continue to be out of control. They're also looking at Medicaid growth and how, in fact, they will participate in providing Medicaid services. And again, if they are a Medicaid health plan, and how do they control costs and utilization for those members? So what kinds of questions do they consider? Should we offer plans on the exchange? We've talked a little bit about that. How do we minimize risk? How do we compete in the marketplace successfully? And then of particular relevance to this group is, what providers are prepared for these newly insured? This is an opportunity for both payers and providers to approach a population in a non-traditional way in order to better manage population health and pursue opportunities other than traditional fee-for-service. Employers continue to see rising medical costs as a problem, results in their premium increases. They're anticipating that the mandate and the insurance exchanges will eventually shift costs to them, which would actually increase their trend. And so what kinds of questions are they considering? Should we still offer health insurance benefits to our employees? We've done a lot of modeling around what are the conditions and the specific characteristics of an employer that will make a decision to move from self-insurance or purchasing insurance to basically discontinuing their health insurance benefit and enabling their employees to access the subsidies and to use those subsidies to purchase care through the exchanges. So again, if we're thinking about the population that's going to be in the exchange, we're looking at a bias, a particular kind of employee in it will be likely to shift into the exchanges. They look to continually, they're continually looking at ways to manage their benefit, and they're sort of questioning whether or not they continue to use healthcare benefits as a way of retaining their employees and their differentiating talent. Providers. What's going on in the market is provider consolidation. That's been going on for many years, but has intensified recently in anticipation of new market drivers, new market characteristics and pressures. And as a part of that, they're looking at trialing more at-risk contracts and selective networks and participating in those networks and making the trade-offs that are necessary to make in order to participate in these programs and the networks. And we talked before about their equation is an attempt to control the reduction in revenue associated with participating in these kinds of programs. So what are they thinking about? So they're thinking about, should we partner with a plan that is looking to be aggressive about offering insurance on the state exchanges, and by doing so, are they positioning themselves for the effect of adverse risk, or if they're in, for example, a fee-for-service situation, what might be the impact on their volume? Are they being asked to care differently for the newly insured? Is this a population health expectation as opposed to a fee-for-service? And should we as a provider organization expand our network to enable us to participate in these new relationships? New slide, please. So now let's look at the characteristics of these newly insured and at least what we anticipate. First major point here is for everyone to realize that these impacts are going to be local. As we talked about earlier on some of the slides, what we see is that the current situation with Medicaid, the decision about whether Medicaid is going to be expanded, will impact the kind of people who show up on the exchanges and the characteristics of those people. This just demonstrates the fact that these are local markets, these are large major markets, and you can see there's a significant difference in terms of not only the number of enrollees that will be added to the commercial insurance exchanges, but the percent. So if you look in New York City, you see a 10% increase in the private insurance, whereas in Pittsburgh you see something less than 5%. And as I suggested before, if you look at San Antonio, Texas, it's the highest with a 25% increase. And if you sort of look over that list at other Texas markets, you'll see that they're all over 15, approaching 20%. Next slide, please. So here's an example. If this just shows basically what county level impact is of a state opting out of the Medicaid expansion and what the effect would be on the insurance exchange. And red basically is where the impact of opting out has the largest increase on sending members into the exchanges. And again, as you can see in Texas and in the South is a concentration of that. The other thing to notice is that there are differences among counties, even in states that are predominantly red or predominantly blue. So what you want to recognize is the fact that your local market may in fact look different. Next slide, please. That just expands on Texas, showing you that the counties are different. So what do we know, or what do we suspect about the newly eligible? So I'm going to look at the Medicaid eligibles, and then we'll look at the exchange eligibles. And we've sort of done this basically with what's going to have a positive impact on the marketplace versus a potentially risky impact on the marketplace. So you can see here a green light. So the newly Medicaid eligible, and the source of this, by the way, is our analysis of the American the Census Bureau's American Community Survey and the CDC's National Health Interview Surveys. And what we're looking at is differences between the newly Medicaid eligible and the existing Medicaid population. So when we say, for example, on biometrics that the newly Medicaid eligible have lower BMI and blood glucose, this is lower than the existing Medicaid population. So we may, in this fact, be looking at a healthier population with lower need for healthcare services. Their health status, they do have a lower level of deterioration and disability, which again has a positive impact on the market. They exercise more. They use less tobacco. They are 2 times less likely to report mental health issues, 3 times less likely to have seen a mental health professional. They have lower levels of chronic conditions, including diabetes, heart disease, and respiratory disease. And they experience lower rates of visits with medical and dental professionals and lower rates of ER use. Now, obviously, the lack of current coverage may impact their use of medical and dental professionals, but probably has less impact on their use of emergency room. And in fact, we see that they're less likely to go to the emergency room. Next slide, please. So let's look at some characteristics that we think of as sort of being neutral in terms of characterizing this population. They are very similar in age. There are slightly fewer women, but not many. They're more likely to be Hispanic, less likely to be U.S. born, but they are more likely to be employed, and we may use that as a proxy for health. But what we don't know is sort of what the real impact of putting all those characteristics are. So we'll assume right now that they're sort of unclear and they're neutral. And we said before, they do exercise more and they use less, and their alcohol use is similar, but when they report their health risk levels, they actually report worse health risk than the existing Medicaid enrollees. Next slide, please. So what's red? What's clearly red is that they're likely to have been uninsured for more than 3 years or never having been insured. And the reason for that is cost. So this is a group of people who may be insured, may be employed, more likely to be employed than existing Medicaid population, but they've never really been able to afford health insurance, and this has been a long-term situation. So what might this mean is that there's a pent-up demand for healthcare services, a pent-up need for healthcare services, and this is something that we need to be aware of. Next slide, please. So now let's look at the newly exchange eligible. So remember, what we've done here is we've sort of applied the eligibility requirements for the exchange and the likelihood of people going to the exchange rather than to Medicaid expansion. So what's positive about this population? They very similar to the newly Medicaid eligible, they have a lower BMI. They report lower rates of visits with medical and dental professionals and have a slightly higher, but they have a slightly higher rate ER use and lower rates of surgeries. So we've identified this as they appear to be somewhat healthy, and we may in fact see that they require less surgical interventions. Next slide, please. Yellow. Similar to the Medicaid, there are fewer women, but there are more younger. So the younger population is more likely to move to the exchanges than into the Medicaid population. This is relative, by the way. This is relative to the existing commercially insured population, just as the previous slides were relative to the existing Medicaid population. So now if we're a health insurer and we're looking at how do these people look relative to our existing insured population, they're much younger, so there's more of them in the 18 to 44 age group. They're more likely to be Hispanic origin, less likely to be a U.S.-born citizen, and obviously less likely to be employed. So these are things that we anticipate characterize this population. What's interesting is that they report mental health issues at a similar rate, but they're less likely to have seen a mental health professional. So again, this may be that there's some pent-up demand. On the other hand, they report lower rate of issues. Similar for other chronic conditions, but sort of a mix with some conditions higher rates of prevalence and some lower. Next slide, please. What do we think of as being red? As with the Medicaid, newly Medicaid eligible, and this was relatively obvious, they've been uninsured for more than 3 years, and cost is has been their concern. They report higher levels of health deterioration than our traditional commercially insured, higher levels of disability and ADL problems. They have much higher use of tobacco, less exercise, and they report a much less favorable health risk levels than our current commercial population. So these suggest that the newly insured on the health exchange are in significant need of services. Next slide, please. So this is an example. If we look at the 19 to 64 age group, health status, disability income 2% lower, health risk 10% more likely to work out, use of medical services 70% have been to the doctor in the last year. So we look at these things in terms of the private versus the uninsured. The uninsured health status 2% worse compared to 2012. They're 15% more likely to smoke, and 35% have been to the doctor in the last year as compared to 70% of the insured. So we begin to look at characterizing these populations, seeing the differences in them, and trying to understand what the impact on service demand will be. Next slide, please. You can open all these. So what are we trying to say? Obviously, in this short period of time, we can't go into many details, but what we're trying to do is suggest that there are new types of uncertainty for the stakeholders. There's certainly interdependencies among the health plans and the provider organizations and the employers or the sponsors of healthcare coverage. A short-term success may just be chance, and what we need to be doing is looking for longer-term success. And what we're suggesting that is important next steps in this for both providers and insurers is to begin to analyze and understand the local impacts in their marketplace. Okay, I'm going to now turn this over to Linda. Linda?
Thanks, Bob. At this point, I'll talk about the opportunities to take some of the context of these drivers and insights to look at ways to manage the population in the context of local market and target audience behavior. Next slide, please. And this, in a nutshell, as Bob has gone over, the findings about what impact the newly insured will have relative to cost. Certainly those in red, the insurance history, the health status, and the health risk will have probably the biggest increase in terms of potential cost and risk in a way that will make this population be significantly different than what we may have seen in prior in the prior Medicaid and the new exchange entries. And what that could well be for those of you who are working in providing care for the uninsured is that we'll see more advanced stage disease, higher incidence rates of cancer and the cancer screening, more advanced stages of specific diseases that are in progress, more advanced stage diabetics, more advanced stage of everything once some of the screenings go through. And that the deterioration will be more specific, which again, for many of you who've been working around this, suggests more care managers and navigators. And health habits and health risk factors will be different. Factors to watch out for are colored in yellow with the chronic conditions and the demographics, and certainly offers an opportunity to have the patient education and the marketing teams really work on ways of engaging populations in a way that speaks in their language and works with their venues. And probably many of you have seen some of the recent literature coming out about the fact that the millennials, the up to 35-year-olds, are much more interested in online help, self-help, web-enabled solutions, which is a good thing and a bad thing. The bad part is the reports from the physician practices or the patient-centered medical homes may not be fully comprehensive about what the needs of these populations are. But the good news is that the virtual connections and the online engagement may be a cheaper way of providing care, of engaging these populations. And again, some of the uses of these healthcare services, we did go ahead and color code the higher rate of the emergency department use, because with the kind of entry point of the newly insured into the health systems by assignment to primary care providers or medical homes, there's an opportunity to really diminish some of that ER use and have a better cost impact or a lower cost impact. Next slide, please. It invites the question of the newly insured, and what does that mean in terms of some of the demand shift and the demand forecasting. And as Bob said, what our goal here is to share with you some of the characteristics of the newly insured, but as a starting baseline, it also helps to know what the opening point is related to any individual market and their utilization rates. And to illustrate that, here what we're showing you is we've got my hometown of Chicago colored in purple. And here what you can see on the top line is the utilization rate of discharges for people who are under 65 years old and the discharges per thousand rate. And compared to other markets like Denver or Salt Lake City, you can see that Chicago's got a much higher utilization rate. So for those of you who are thinking, so why are these use rates so different? What our scientists find is that the utilization rates are driven off of a combination of local factors. One is the population and the demographic makeup, better known as the people. The second is the type of payer mix or payer coverage that's in a particular market, since demand is often a function of coverage. And then the third factor is the local provider community itself, sometimes demonstrated by the number of academic medical centers, but really it is the provider practices that really make that third driver of what use rates look like in any particular market. The issue here is the illustration of the variation of the local market. And for those of you doing business in different markets, even for many doing business in Chicago, the suburban market and the urban market use rates are significantly different. And you can see that that stands true also for the outpatient. Here we have the stent procedures on comparative market rates. Again, that's under 65-year-old outpatient procedures per 1,000 population. And you can see the line across the Chicago at about 5,000 being significantly different from Austin or Raleigh compared to Sacramento and San Jose. So in modeling what's the demand forecast, which is sort of the ultimate goal of, so what kind of volume are we looking at and what kind of people are we looking at, it helps to start with a baseline of how is our market different and potentially adding not only what kind of utilization will we expect with the newly insured, but how will that be impacted based on the current market use rates, and what might happen if we started sizing to a different market utilization rate. So if we can also go to the next slide, please. Then the question will come, what about looking at some of the key risk factors? And here's a profile of what, in working with one health system, they considered their baseline of, okay, so here we are looking at a particular set of zip codes in 2011. Seems like a very calm time before reform sets in, and there's a tremendous amount of uncertainty. And you can see this actually starts prioritizing zip codes in terms of the degree of intensity about chronic conditions. So if you could press that again, please. And again, it's the zip codes with the highest combined index of concentration that actually translates into, okay, so now we have the top zip codes, that we then take those top zip codes and transform them into who are the top market segments who have that high index of concentration relative to chronic conditions, who would be the highest risk health consumers. And if we can go to the next one, please. And then, again, what are the unique needs of these segments and what's some of the variability? What one health system went ahead and did is said, just give me who the key segments are. And the clinical team said with these, almost the equivalent of baseball cards, these profiles of the 65-year-olds who make $25,000 a year, very different from the second highest risk segment, which is the mobility blues, those who are making almost the same dollar amount but are under 25 years old. The clinical teams were able to say, okay, so now we know how to design interventions. So it's one way, again, to really focus on not just the demand forecast, but the expectation of what are the behavioral implications, and go ahead and start looking at some of the interventions. So if we can go to the next slide, please. Again, with the focus of how to manage a population in the context of the newly insured, one of the key issues is around leakage. What you're looking at here is a profile of the Chicago market and comparative outpatient market shares of diagnostic and treatment for breast cancer. The lightest shade of blue is the ultrasound for breast ultrasounds, which again is a diagnostic procedure that follows mammograms, and you can see that that's in light blue. The relationship of the light blue bar to the rest of the bars, if you could press advance, please, shows you some of the indications of where is there a balance of contained volume, where the balance of diagnostic procedures is comparable to the balance of the treated procedures. So here in this profile of the Chicago market, Rush University Medical Center has a comparable amount of both diagnostic and treatment types of procedures related to breast surgery. But it does bring home the question of, is there a leakage issue, and does there need to be more of a containment issue? And again, in looking at the impact of the newly insured, if there's a fair amount of fragmentation, then at the same time that narrow networks become a key factor, bringing in more of a population into this is going to be key for managing this population with having some of those containment strategies. And here you can see with the yellow highlighted and the red highlighted, a real imbalance of diagnostic versus treatment procedures, where happily those with a lot of treatment procedures are getting good, profitable surgical cases. On the other hand, it's coming from outside the market or outside the health system that imposes somewhat of a vulnerability, especially as providers move into narrow networks and work with health systems that actually have more leakage prevention. So again, it's an opportunity to be thinking about how to manage the population in light of some of the leakage. And while payer incentives will make a difference, it also helps to consider what the service line teams need to do to help with patient compliance. And if we could have the next slide, please. And the next one. Thank you for the bills. One of the things that, one of the tactics of managing the population in the context of the local and target market behavior is this profile I have here of Broward County, Florida, which is actually just a market profile of how many emergency department visits are actually urgent. And in this market, the providers have been extremely active in having access outside of the emergency department, so that in fact you can see that 65% of their emergency departments in Broward County, not particular provider, but a reflection of the marketplace, are urgent, and again consistent with the national average of 65%. However, we have seen when we look across markets that in fact a number of emergency department volumes are actually as low as 43% of the visits being urgent care, or as high as 99%. So the opportunity for redoing or redirecting visits out of the emergency department, if we're all in fee for value, has a national opportunity of saving $4 billion a year if 20% are treated in a lower cost service area. And for a number of healthcare providers, we've heard that the emergency department's not the Department of Available Medicine. There is an interest in redirecting patients into physician practices or expanding capacity. The challenge of the newly insured is if there's a greater familiarity of using the emergency department, and certainly Medicaid has a higher utilization rate of emergency departments, managing the capacity, the demand, and potentially redirecting is really, really critical. And as long as we're straddling a multi-payer environment, then one of the challenges will be not avoiding an overflow of demand on the emergency department, so there isn't a need to go on bypass and miss the profitable kinds of cases that might otherwise be using the hospital's ICU beds. So again, the emergency department, as many of you are probably working on, has a huge front door implication. And again, in the case of the newly insured, one where the overrun could potentially risk some of the profitability of the other system. And the opportunities include sort of redirecting super users, expanding offline capacity, and working on, again, messaging, especially to the younger population, about what they can do to manage some of their own health. And if we can go to the next slide, please. So at this point, one of the things, if you said, well, so what would we suggest as we start looking at some of the demands, is to help the teams start really using the use rates and understand the demand patterns and set up their own interventional programs as needed. And if we could go to the next slide, please. The iceberg is melting is a good way to just talk about how huge this shift is. And I'm sure that, again, with the many of you that are attending, this is something that's very much on your mind. But this is a multi-generational paradigm shift of the uninsured virtually disappearing, as Bob described earlier, and moving into an insurance status that will come with years of transitions as demand being a function of coverage starts shifting between now and 2018. So if we could just punch through bring the slide alive, keep going, please. So the first part is those of you who are on the line certainly know about the urgency factors, and so hopefully this webinar, to Bob's and my hope, is to arm you with how deep is the impact so that you can set the urgency forward and use this to galvanize some of your guiding teams. And if you can go to the next slide, please. It's often like this picture of what we're going to show you of people being in the boat, and you can, again, in this new system where we have the onslaught of the demand from the newly insured, want to make sure there's capacity in the right place. We really do need a balanced boat. Feel free to use this at home. So if I could, next slide, is just share with you a couple of insights or thoughts of looking at the Chicago area profile. Let me share with you sort of an all-in integration set of opportunities as you're looking at your demand forecast. We would say that Chicago would be certainly this big a geography. And if you can go to the next slide, let's take a look at the payer-covered lives and how much they're shifting. So as you can see here, we've got a scope and scale of measurement on the uninsured and the Medicaid. The interesting news is the uninsured will go down, so that's going to really change things most specifically. But the new opportunity of what is in front of us is the increase in the Medicaid and the private exchanges. And as we start looking at this, I wanted to highlight the Medicare because in some markets and working with some health systems, we found that in fact the impact of Medicare which is quiet and not as celebrated as the impact of the newly insured, is a huge shift when we start thinking about the baby boomers at about 111 discharges per thousand, aging into 65-plus status, where they actually move into 344 discharges per thousand. Now, that doesn't happen overnight, but the magnitude of shift is certainly one that is certainly not minor at all. And so, again, I wanted to share with you what the impact is relative to what Chicago starts to look like in looking at a whole marketplace as you start looking at a demand forecast. And if we could go to the next slide, please. Breaking that down more specifically to the patient profiles is an age and gender distribution. On the left is the new Medicaid, and you can see the impact on the age-sex variation. And why this is helpful is to identify what's the impact for the service lines as they look at the difference in male-female. Certainly there's a significant play in terms of the women. If you look on the right in terms of the private exchanges, you'll see the impact again on the 18 to 34-year-olds. We're really looking at those millennials, and a big shift in men's health. So this will probably have significant impact by service lines, and then look at raise some questions about the kinds of affinity groups or engagement around women's health, and raises almost a new context for the men's health given the magnitude of growth in insurance from the men who are coming through some of the private exchanges in the Medicaid. And again, key components to put in front of your service line teams. Next slide, please. As you ask them to consider managing the impact of the newly insured. So on a step-by-step basis, these are some of the suggestions or factors that we would bring forward as a suggestion of dealing with the impact of the newly insured, is to create the urgency with the volume forecast. Please feel free to go ahead and build that, Lindsay. And having the primary care team, because that kind of intervention will be really key, as we start looking at, or as the various care teams start looking at what kind of change in primary care will we go ahead and deliver. And I know a number of health systems have said we've changed how we do primary care. It's not the 1 hour or 40 minutes in the physician offices. It's a primary care screening program that's almost operated on a retail basis. And again, the intent here is to be able to build some of the capacity for changing the consumer engaged culture, to create a sustainable model of care delivery for these newly insured who actually are not as interested in engaging in the healthcare system at the same rate as their forebears. And if we can go to the next slide, please. And I would imagine you'd probably start thinking about, so what does it mean in terms of some of the disease priorities so we can really make sure we've got the right clinical focus points. So here I'm sharing with you what kind of changes might really come about between now and 2018 in terms of the diseases, and what will be the first here, which you can see are musculoskeletal, respiratory and digestive, metabolic. Next will be the heart, the immune system, and behavioral. And so tiering this to look at what kind of increases will come up. Again, there will be variation by local market, but will help in identifying what kind of structures and processes are going to be needed in preparing some of the demand and capacity futures. And then, of course, the great opportunity is, please, next slide, is the coordination of care. And in the coordination of care alone, there's a huge opportunity in fee for value. I think earlier I shared with you some of our findings that if 20% of the patients who are currently being seen in the ED get moved to a new site location, there's a savings annually of $4.4 billion. But just care coordination takes up the $50 billion. So in short, next slide, please. Sort of the nuggets to take away is that 14 million Americans are going to get insurance just in 2014, but that number goes up to 34 million by 2017. Think local, be ready to take on risk, know the market. Capacity will be key, but of course, as your teams move forward, the right care for the right patient in the right site by the right provider, to go ahead and then engage the newly insured personally, because they may not come to us as much as we would have otherwise expected. And with that, I think Bob and I would be delighted to take questions or comments.
Great. Thank you, Bob and Linda, for a very informative presentation. We're now going to begin the question and answer portion of our program. And just to remind all our attendees, you can submit any questions that you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we just have a few minutes left, but we're going to attempt to answer at least a couple questions, and then our presenters will receive any questions they did not have the opportunity to address on our call today, and then they can follow up about those. So with that, I'm going to jump to one of our first questions here, which really kind of takes a step back and asks, what are some of the driving factors of the newly insured? And maybe briefly in the second part of this question, you could discuss, and how is that impacting the industry?
Well, this is Bob. I mean, I think uncertainty is probably the key here. Is that we have suspicions, we have forecasts about what this population looks like. We have predictions about what their utilization would look like, given the fact that they haven't had access to healthcare services, consistent access to healthcare services in the past. We have thoughts about pent-up need for services. But what I think what the driver is this uncertainty and the ability to prepare for this level of uncertainty and respond. I think we do recognize the fact that these people will not be familiar with using the healthcare system, will sort of not have the advantage of having had years of learning how to access care, how to manage their own use of services, and that there's going to be a great need for support, as Linda describes, in order to sort of effectively deal with this different population.
Great. Well, I have another interesting question that came in, which says, I've seen, a few news reports estimating that some of those eligible for the exchanges, perhaps a large percentage, may not decide to purchase health insurance on the exchanges just because of the large expense and will instead opt to pay the fine. I guess any thoughts for hospitals on what the impact of that will be and how they can think about how that might impact, their planning?
Well, obviously, the expected impact of that will be is that they'll be the healthier individuals that will decide to go, bear on insurance and pay what is not a sufficient disincentive to do that. So the effect being that the enrollees in the exchange will, in a way, look, we'll call them worse than what we've shown here, which here suggests that there'll sort of be an even selection of participation in the exchange. So I think the idea is that we just don't know, but we certainly would suspect that the people who opt out are going to be the healthier population, and we're going to be left with a much sicker, more chronically ill population in the exchanges. So I think that healthcare systems are going to have to prepare themselves for that kind of demand, and as Linda says, eventually need to provide care in the most efficient and the most effective way possible for that population. Won't be able to afford, the insurance plans won't be able to afford sort of the existing costs associated with caring for those people.
Great.
Although in addition to Bob's comments, there is an opportunity for providers to consider how they function on that self-shopping retail, a retail available healthcare information or engagement, because they're going to be healthier, and they also might be looking at sort of a minimal engagement process. So to the extent that retail health services are available for the cost-conscious, maybe another sort of path to develop.
Great. And
yeah,
I
that's
think,
a great point.
And as we come to a close on our time here, I think we'll just end with one more question. And thank you to all of those of you who have submitted questions. And again, our presenters will receive those in follow-up. The last question, I think, is an interesting one, which is just kind of your thoughts on how providers can think about this idea that even though people might have insurance, go to insurance, they're currently uninsured, they get insurance on the exchange, they might select one of the lower cost plans that are going to have significant out-of-pocket requirements. And just what can we think about in that in terms of, will they use their the coverage that they have if they have little discretionary income to pay those out-of-pocket costs?
Well, I think that was an obvious concern with the Act and its definition of covered services, and the fact that one of the constraints that we've already seen implemented is the requirement that preventive type services be covered at 100%. So I think that there is a recognition of the fact that those people who sort of buy that lower level plan would have a disincentive to use services, and requirement that the plans cover the kinds of services that we expect people to feel comfortable and to not have any constraints on accessing.
Great. Well, thank you. Oh, did you have more to add?
I was going to say, Noelle, I just wanted to sort of point out that I thought Bob's comment was great, because it really does show how we're going to have a completely different model of healthcare delivery for the populations that, Lindsay, these questions are really well highlighting.
Great. Well, thank you to our presenters and to everyone who attended and asked questions. Thank you for your excellent presentation and participating today. We look forward to having you join us on future webinars. This concludes today's program. Have a wonderful afternoon.